to Fertile Talks, the global podcast celebrating the diversity of fertility journeys. I'm your host, Dr. Yemi Famuyiwa. Whether you're just starting or simply curious, this is your safe space. In each episode, we will bring you expert insights, heartfelt personal stories, and the latest in reproductive health. Our goal is to break down barriers, tackle stigma, and provide support and hope. So, whether you're in the Americas, Africa, or Asia, Fertile Talks is your companion on the path to parenthood. Thank you for tuning in and welcome to Fertile Talks. All right, good evening, everyone, and welcome to our second webinar in the series on reproductive immunology. So tonight I have Dr. Masuri Atia with me again. And if you didn't see the first webinar, I'm going to refer you to go look it up on our website, where we had a lively discussion about reproductive immunology. And we discussed what it is and how it can impact both pregnancy and also fertility. So I'm going to let Dr. Masuri Atia is from France, and she has a master's and PhD in reproductive immunology. And she works as a scientific director for Pregmune. Pregmune does a lot of immunology testing that is helping us make better diagnosis for our patients. So I'm going to let Dr. Masuri Atia introduce herself some more so she can let you get to know her better. Go ahead,
Thank
Dr.
you.
Masuri.
Good evening, everyone. Thank you, Dr. Famuyiwa, for the kind introduction. Very happy to be here with you tonight. So my name is Nadira Mansouriatia. Just call me Dr. Nadira. That will be good enough. I'm coming from France, and I'm the Chief Operating Officer and the Chief Scientific Officer at Pregmune. So Pregmune is a company created back in 2020, fairly new in the market. We are using artificial intelligence combined with extensive immune testing that includes genetic testing, metabolic testing, thyroid panel, you name it, we do it. And we are combining all those results within a report called the IRMA report that will give you a comprehensive overview of the potential cause of your fertility struggle. So based on your results, we are compiling that report, the IRMA report, that will give you a clear understanding of your results and how this can impact your chance for success. And we are also providing you with a score, the IRMA score, that will give you the likelihood, based on your results, to be successful with a live birth.
Excellent. So thank you so much for filling that in. So what I'm going to do before we dive in today, because we decided that the topic for today was so extensive that it will be very difficult to cover everything in one go. So we're going to try and split it into two, and this is part one. So before we jump into part one, we're talking about the treatment now, and how do we monitor the response? How do we treat the patient? How do we monitor the response? But before we go into treatment, just to recap a little bit, the last time we talked about what could go wrong when someone's trying to get pregnant and it's not working, or they keep losing the pregnancy. And we discussed the fact that when you look at a pregnancy, you look at the embryo like a seed that has to implant into the uterus with the soil. And so many things could go wrong with either the uterus not recognizing the embryo, the mommy is not recognizing the embryo, or could be the problem where the embryo doesn't have all the requirements for it to safely lodge into the baby. So again, I'm going to have you look at that again, because it's really exciting to go over the what we would look to test for the patient. So what we want to do is how do we treat a patient who may have immune problems? What kind of treatment would we give to the patient, right? When do we use treatments such as steroids, right? What kind of steroids would we need, such as prednisone? And also, what treatment would we use for someone who may need a blood thinner? Why would you use a blood thinner? Why would you use low dose aspirin? And we're going to talk about what we call immunomodulators, something called a colony stimulating factor. How would we use progesterone, prednisone, a steroid? How would that help us in trying to achieve pregnancy or maintain pregnancy?
Yeah. So yeah, let's dive into it. Let's start with prednisone. Prednisone is a drug that you will have to take orally. It's a corticosteroid that is used to suppress the immune system. This is the main action of prednisone. So it will act by decreasing your inflammation. It mimics an hormone that is naturally produced by your adrenal glands that it's called cortisol. So prednisone will act on three different parameters. The main goal is really to suppress the inflammation. It will act also by modulating your immune system and by promoting immune tolerance. I will get back into it in 2 seconds. And it will also play a key role in suppressing autoimmunity. So let's start with the inflammation.
Yeah,
For the implantation to occur, you might know that you need some type of inflammation, some level of inflammation.
exactly.
You don't need to suppress the immune system completely. It doesn't have
Right.
to be shut off.
Doctor, I'm going to break down a little
Yeah.
bit. So what happens is, let's say you have, your soil. I'm going to use this as your soil, and the embryo comes in and is going to come in contact with the soil, right, in the uterus lining. That initial contact is called apposition. There has to be some inflammation that occurs to dig a hole in that lining so that the embryo can start to bury in. So you need some inflammation to allow the embryo to start to tunnel in. But once the embryo has gained a foothold and has started to tunnel into the lining, then you don't want that inflammation anymore. You want to turn that inflammation off, right? So you don't want any inflammation at that point, right? So then it's really weird, because you need the first you do some inflammation, then you'd want to stop the inflammation, right? You want to stop
Correct.
the inflammation after a while,
Yeah.
right?
So yeah, inflammation can definitely impact a process called decidualization. So this is a process that will take place within your uterine cells, within your uterus, and that will make the cells more receptive to a potential pregnancy and embryo apposition. So inflammation can totally disrupt that process. So that will also jeopardize the implantation of the embryo. It can act also by suppressing the formation of blood vessels that you need to be able to have the invasion of the embryo within your endometrial lining. So inflammation is a big culprit of implantation failure, and prednisone will act by
Right.
suppressing that inflammation.
Exactly. So, in other words, after the initial inflammation to allow the embryo to get in, now it should turn off, right?
Exactly,
That there
yeah.
are systems to turn it off. But if instead it doesn't turn off, now you have a very inflammatory state. That which had originally allowed the embryo to get in now starts to work against the embryo, and it starts to treat it as if, oh my gosh, this is a disease process, it's an
Exactly.
infection. I need to attack it, I need to clean it out, right? So that's prednisone prevents that marshaling of the body's immune defenses to now attack the embryo, right?
That's totally correct. Yeah.
Exactly. So now when we start progesterone, how do we know if we have enough, and how do we know not to overdo it? Like what are we looking for? How long do we treat it? And how do we know if we're in the range where we want it?
Yeah, so prednisone, as I mentioned, is acting on inflammation, and it's also acting on autoimmunity. So we
Right.
are using prednisone mostly for two different factors. First
Right.
one is inflammation. So
Right.
at PregImmune, we are testing for a Th1 on Th2 ratio. That's a measure of your inflammatory level. So basically, we are measuring within a specific immune cell type called helper T cells. We are looking at the pro-inflammatory interferon gamma divided by the anti-inflammatory IL-4. And that ratio will give you an idea of your inflammation level. If it's too high, then prednisone is the drug of choice to try to lower this down. So that will be
Exactly.
the first type of treatment you can have, and we can use prednisone for that. We also use prednisone when the patient has autoimmunity, and that will be seen with the production of antibodies, autoantibodies, antiphospholipid antibody. We
Correct.
talk about it
Yeah.
during the first
So
webinar.
tell me, so when you're monitoring it, you're testing the IL-4 and you're looking at the Th1, Th2 ratio, correct?
Correct, yeah.
Okay, how often do you measure that?
So that's a test that is run at baseline when the woman is not pregnant.
Right.
We are determining if there is an underlying issue with inflammation, in which case she will be placed on prednisone prior to the pregnancy.
Exactly.
Once pregnant, we are monitoring those parameters every 2 weeks from the time of the positive pregnancy test up to 12 weeks. So every 2 weeks, we are able to see if the inflammation level are optimized and reduced if they were too high.
So the goal is to give just enough prednisone to get within the range we want and not overdo it. Because there is such a thing as prednisone toxicity, right? We don't want to cross over into where we start getting side effects.
That's correct, yeah. And that's why we need to monitor that drug efficiency. There is some dosage adjustment that we can recommend. That's why we are screening every 2 weeks.
Right.
The recommendations are really based on that specific stage of pregnancy. What you need during the implantation is not what you will need at 10 weeks of pregnancy. So we are able to adjust dosage if needed.
Excellent. And I would add that with prednisone, we want to make sure that the patient doesn't have peptic ulcers, because it may be contraindicated if they do, so they don't get ulcers. And also prednisone is usually used in the morning when the body's own peak cortisol levels active. So you have minimal suppression of the adrenals, because we don't want over suppression of the adrenals.
Yeah.
Now, and one thing I tell my patients is people who have been on prednisone at a high dose for a while, when they're coming off it, we actually put them on a taper. We don't just, stop it. We taper them off to get off.
Yeah,
right.
That's correct. Yeah. So usually we are decreasing the dose by half every week. So let's say that the patient start at 30 milligram a day.
Yeah.
We will decrease to 20 milligrams. She will stay on that dose for a full week. Following week, it will be 10. Following, it will be 5. And after that, we can totally stop. So usually we are starting tapering off around 12 weeks.
Around 12 weeks, and then you taper and stop.
Yeah,
all right,
correct.
Great.
Yeah.
So that's how we use prednisone. Now, the next thing that we use, they're a little similar, but they're very different. And one is low dose aspirin, and the other one is a blood thinner, low molecular weight heparin.
Yeah.
So let's tackle those two together. When would you recommend those two?
So we will recommend low-dose aspirin in combination with Lovenox when a patient has a positivity for antiphospholipid antibody. So again, this can increase the risk for blood clots. If we are detecting some mutation for specific gene in the thrombophilia panel, so we are looking for factor 2, we are looking for factor 5, we are looking for PI1. If the patient has a mutation of 1, allele or two in those three genes, then we are going to recommend that cocktail of two therapy, just because that
Right.
may place them into an higher risk for blood
Right.
clotting. So we want to minimize that risk.
Right. So I will remind our audience, if you listen to the first webinar, we had talked about why do you need to thin the blood? There are some patients who have elevated coagulation factors that tend to form clots easily. And there's a belief that there could be clot formation at the placental level where the growing placenta is growing into the uterus. And if you form micro clots at that level, that could shear off the placenta and increase your chances of recurrent pregnancy loss. So that's why we would use it. But like anything else, we have to monitor it, right? So we have to say how much is too much and what are the side effects that we need to look for.
Yeah, so low dose aspirin is used usually at 81 milligram. That's what we call baby aspirin.
Mm-hmm.
Nothing to look at for the aspirin itself.
Yeah.
Now for the Lovenox, after starting Lovenox, 1 week after starting your treatment, and 4 hours after your morning dose, you will have to get a test called anti-XA assay that will give us an idea of whether or not we are within that optimal range of dose for Lovenox. If you are within that optimal range, good. You are going to be screened anyway every 2 weeks through an AMI report, specifically for the APA, because really that might be one of the first cause for the doctor to place you on blood thinner. If those levels are out of range, we can either increase or decrease your dose of Lovenox.
And I'll just cap in there just to give our audience some background. When you give low molecular weight heparin, it's not like giving heparin, right? So it's not going to prolong your PTT. You're not going to look for a PTT prolongation because it works, because of it's 4 to 5 kilodaltons, and it's a lower weight than regular heparin. So it doesn't affect the PTT, but it will affect an entity called the factor 10A, XA 10A. And that's what we can measure. And you measure that how often and till when?
So this is really measured very early on, whenever the patient is placed on Lovenox, to determine if the dose given is the right one. So 1 week after starting, you are going to be screened for that anti-XA assay.
Okay. So 1 week after starting, and then how often after that?
Just once.
Once.
If you are falling within normal range, no need to repeat that test.
Okay.
Of course, if there are some dose adjustments, you have to repeat another full week after that adjustment.
Okay. So once we get the right dose, we keep it on there, and then we don't check again. Now, again, Lovenox, there can be toxicity, and so I like to monitor my patients with the help of a hematologist as well. So because if you have a toxicity, you can reverse it with something called protamine sulfate there. All right, excellent. So those are fairly straightforward. Now, the most exciting one, I think, is colony stimulating factor. What is colony stimulating factor?
So GCSF, as you mentioned, it stands for granulocyte colony stimulating factor.
Yeah.
You might know it under the name Neupogen.
Exactly.
A lot of testimony of Neupogen baby. So this is an injection. This is a drug to inject on your abdomen daily that will increase your white blood cell count. So what it does, it has multiple effect on your immune system. It will modulate your immune system by shifting your balance. We talk about the Th1 and Th2 ratio. So it will play and shift that balance from a pro-inflammatory profile towards an anti-inflammatory profile. So more of a Th2 type of bias.
Response.
Which is what we want during the pregnancy. It will also play a key role on specific immune cells called regulatory T cells that are promoting immune tolerance. Just so you know, in your body, you are producing GCSF, is a natural drug, a chemical in your body. You have receptor for that GCSF on your ovaries. So that is involved in the production of your egg. You have GCSF in your uterus, receptor as well
Right.
in your uterus, and the
Yeah.
embryo has both receptor and
Right.
that protein is secreted by the embryo. So it has
Mm.
a lot of effect on
Mm.
the immune system, on your oocyte quality. It
Mm.
helps promote immune tolerance by boosting the production of regulatory T cells. Not only does it boost their production, it also helps their recruitment from the blood to your
Yes.
uterus where they need to have
Right.
their action.
So I'll also just chime in here and say the regulatory T cells, we call them Tregs,
Mhm.
are part of the cells. We talked about turning off the inflammation. The thing that turns it off are the Tregs, right? So you want your Tregs to be high in the uterus and turn off that immune attack on the embryo. So Neupogen or GCSF helps to decrease that. Now I must add there there are three types of colony stimulating factor, and the one we're looking at is the GCSF,
Yeah.
not the GMCSF or the MCSF, which increase the macrophages because those are actually more inflammatory than the GCSF. Only GCSF is used for this.
Yeah, that's correct. Yeah. And
Right.
GCSF will also have a direct effect on your embryo. It will help the embryo to invade the uterus. So that's why we really want to start Neupogen early on,
Mhm.
prior to the transfer, because it will
Mhm.
help prime your uterus to welcome
Right.
the embryo and allow the pregnancy to occur.
Now, I do know that there are some protocols and some research has been done out there where they use Neupogen intrauterine,
Yeah.
right, for people with very thin lining, just recalcitrant uterus. You might actually put it in the uterus, and those patients, when you use it in the uterus, actually you have fewer side effects, right? You don't have the white shift. Can
No,
you
you won't.
comment? You've seen? Have you? Can you comment on protocols where they've used it in the uterus versus injecting it, and or both? I've seen both been done both ways.
So yeah, the two protocols are used for two different type of scenario. You
Yes,
are using intrauterine flush with Neupogen for, as you mentioned, women
thin.
with thin lining. So that will
Yeah.
help thickening their endometrial lining.
Mm,
That will also help to increase their endometrial receptivity. So
mm.
the effect here is really local, no
Local.
immune modulation
Right.
for the patient who got the injection. So that will be a systemic effect. And
Mm.
in that case, you will have the immune modulation with the boost of regulatory T cells, and you will see an increase, a significant increase in white blood cell count, totally normal. And that's something we are monitoring as well.
Yeah. So so let's say I give Neupogen and I'm giving it as an injection. How often do we check what it's doing?
Yeah. So Neupogen, once you are on it for a couple of days, you will
Mm.
have to get a CBC. So a CBC is a numeration of your blood cell, including white blood cell count.
Right.
We are going to measure the white blood cell count, the platelet as well. And we
Yeah.
don't want, we want to see an increase. That's
Yeah.
what, how we measure that the drug is efficiently processed by your body. But we don't want to exceed 20,000
Right.
for the white blood cell count.
Mhm.
We want to maintain it definitely below 30, and around
Right.
20 is the best. But we need to see that increase to be able to tell you that
It's doing something.
it's
Right.
doing the job. Yeah.
So if it goes above 30, then we back off on the dose and
We
repeat the
stop.
test.
We
We
stop for
stop.
a couple of days, and then we resume to a lower dose.
Okay. Excellent. So now one of the things I wanted to mention is we talked about, now we haven't mentioned the other three things we could do to treatment, three or four things we and the novel treatments, and we'll do that in our next session. So what you do instead, you put out a report depending on what the patient's on, and you would send it out every week or every 2 weeks, however many times the patient needs it, so that it guides their physicians in saying, well, I need to go up, I need to go down, or stay the same. what's that report called, and how often do you generate it?
Yeah, so the report is called the AMI report. It includes a full immune panel. So you have a total of 27 tests, and we are looking for all the cytokine in all the different immune cell type. We are also running a CBC, so a count of your white blood cell count and your
Yeah.
platelet, as well as a APA panel to try to determine if there is some APA, antiphospholipid antibody positivity. We are looking at vitamin D as well. So we are starting once the patient is pregnant. We are running that full panel every 2 weeks until 12 weeks. So any time we have a red flag or we see a red flag of an increase in inflammation, so that can be seen by the Th1 and Th2 ratio we talk about, that can be seen by an increase in the concentration of antibody or many other cytokines that are linked to potential loss. The red flag is raised, and we can say to your physician, adjust your prednisone dose, increase, because we want to counteract that inflammation and maintain it at bay to the pregnancy to progress. Yeah.
Right. And I must add, sometimes you modify your dosage um, so you don't over suppress someone with Neupogen if there's a risk. I know during COVID, some patients who were on it had to have their dosage modified because we don't want to suppress them when there's a pandemic around. Excellent. Thank you so much. So I think we get a sense. So from this, we talked about three major therapies. One is the steroid, the prednisone. What are the risks to look for, and how often do we check it? We talked about blood thinners such as aspirin and Lovenox, low molecular weight heparin. And then we talked about one of a novel one, which is the colony stimulating factor, which originally was used in a lot in renal patients or patients who are going through transplant, whatever. So this is an off-label use of this therapy, correct?
Yeah, completely. Yeah, it's not FDA approved for the purpose of fertility, but that's a drug that has been used for the past 15 years. It's new, but not that new.
It's new, but not new. Yeah. Correct. Yeah. Thank you so much. And any other last minute things you want to summarize for our audience?
Yeah, I just want to say that before using any drug, you have to get tested to see if there is a need to use that specific drug.
Yes.
And if you are, then you need to have a close monitoring to make sure that you are not over using that drug, and that it can stay beneficial for the outcome of the pregnancy. Very important.
Excellent. So basically, it's not a do-it-yourself DIY project. Don't get it from a chat group, because I was alarmed when I saw some Facebook groups, and you can go overseas and get any kind of medication. So please know there has to be a reason why you're using this. You have to be tested and you have to be monitored. And when we monitor, we try to do more like a team monitoring, because I usually get the hematologist involved, I get the patient's primary care involved, and I also involve their OBGYN, so that we're all on the same page with the end goal of achieving a successful outcome for the pregnancy. Thank you so much, Dr. Masuriati. I can't wait for the next session. I'm excited. Thank you for tuning in to Fertile Talks. We hope today's episode has provided you with valuable insights and support for your fertility journey. Remember, you are not alone. Now, if you have any questions or topics you'd like us to cover, please simply leave us a comment. And please don't forget to like, share, and subscribe with a friend. Your ratings, your shares, and your reviews are greatly appreciated, and is going to help us serve more of our listening audience. Thank you once again. This is Dr. Famiyiwa.